Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about the radiographic localization of a mediastinal mass, still continuing on our discussion on the mediastinum. We'll first start off with detection of an anterior mediastinal mass or a prevascular mediastinal mass. So the radiographic features we should be looking out for. When you have deformation of the anterior junction line, you remember in our previous discussion, we mentioned a little bit about the lines and stripes that we would see in the mediastinum. So we are going to build on that knowledge. So deformation of the anterior junction line suggests a prevascular mediastinal mass, since you remember the anterior junction line is the anterior junction of the left and right lungs. So that makes sense. However, since the anterior junction line is not always seen, it's more common to rather infer indirectly the anterior location of a mass by the preservation of the posterior lines in the presence of a mass. So you see a mass, but then the posterior lines are still there. You can infer from that it's not a posterior mediastinal mass. However, it could be an anterior mediastinal mass. Then we have the hilum overlay sign, and this is present on the frontal view if the hilar vessels are visualized running through the mass. That indicates that the mass cannot be coming from the visceral mediastinum. So it may either be anterior, which is most likely, or posterior. So seeing the hilar overlay sign only eliminates a middle or a visceral mediastinal lesion. Then you can use other things to now determine whether it's anterior or posterior. Also, obliteration of the retrosternal clear space on a lateral radiograph is a direct sign of prevascular mediastinal location of a lesion. So in these images, the first one is a frontal radiograph, and it shows a right mediastinal mass with silhouetting of the right heart border. There's some silhouetting of the right heart border, and we can also see that the pulmonary artery is visibly running through this mass, representing the hilum overlay sign. And this also indicates that the mass is not in the middle mediastinum. Then on the lateral radiograph, we see the mass in the retrosternal clear space directly behind the sternum. And this confirms its anterior mediastinal location. This was later found to be a teratoma. Then for the middle mediastinal masses, distortion of the azygosophageal recess, distortion of the posterior junction line, distortion of the paratracheal stripes, or an outward convexity of the aortopulmonary window would suggest a visceral compartment mediastinal mass. So in these images, we see a displacement of the descending aortic stripe. If we follow this stripe, it's supposed to be the descending aortic stripe, but it bows outward towards the left here. And then after a contrast enhanced axial CT, we see this non-enhancing homogeneous mass effacing the esophagus. This was a liposarcoma, which is quite rare, but the point is the plain frontal radiograph gave us an indication that there is a visceral compartment mediastinal lesion bowing the aortic stripe. Then for posterior mediastinal masses, distortion or displacement of the paraspinal lines suggests paravertebral disease. Also, a mass that extends above the clavicles is a strong indicator of a posterior mediastinal lesion, as the anterior mediastinum ends at the level of the clavicles. Also, a negative cervicothoracic sign, which we'll come to understand in the next set of slides, would suggest a posterior location of a lesion. And by negative cervicothoracic sign, I mean when we see a lesion in the upper mediastinum, in order to tell whether it is anterior located or posteriorly located, we try to see whether above the level of the clavicle, the lesion can still be well outlined. If it's well outlined, even above the level of the clavicle, it's most likely to be posteriorly located. So in this image, we see this superior mediastinal lesion that appears to be still well outlined inferior to the clavicle, behind the clavicle, and above the level of the clavicle, telling us this is unlikely to be an anterior mediastinal lesion and rather posterior mediastinum. So let's dive a little deeper into the cervicothoracic sign to understand exactly what we mean. So we should understand the anatomy of the thoracic inlet. And this is a volume rendered 3-dimensional CT image in the sagittal projection, and it demonstrates the relationship of the lung apex, shown by these arrows, to the right clavicle here and the first rib here. And these are key landmarks for the cervicothoracic sign. The lungs and the trachea here are indicated by blue. Okay, now the course of the first rib defines the thoracic inlet. This is the first rib. This is what defines the thoracic inlet. And this separates the lower neck from the mediastinum inferiorly. Now note that the first rib is higher posteriorly than anteriorly. And the upper aspect of the lung, as you can see, follows this course, right? Therefore, posteriorly in the thorax, the lung apices are above the level of the clavicle. You can see the clavicle here. And you can see that if we were to draw a horizontal line across, we would see that the apices of the lung posteriorly are above the level of the clavicle. Anteriorly, the uppermost aspects of the lungs are the level of the anterior first rib and inferior to the proximal clavicle anteriorly. So that would mean that if you have a lesion anterior to the chest, it would be limited by the clavicle superiorly. However, posteriorly, the lesions are not limited by the clavicle and can go above the level of the clavicle. So if you have a mediastinal lesion in the posterior mediastinum superiorly, you will still be able to see lung parenchyma on both sides of the lesion. That will make it well outlined. Okay, so that explains the negative cervicothoracic sign. Also, I understand the term cervicothoracic, calling it negative or positive, in the sense that cervicothoracic means moving from cervical region into the thorax. So cervicothoracic. Based on the anatomy, it's easier for structures to move from the neck down into the thorax because there's no resistance, and because of the retrosternal space, it's just a space, so it's very easy to just move down into the space. However, if you have an anterior mediastinal lesion growing very large, it's unlikely to extend above the level of the clavicles, because as it extends upwards, it reaches the level of the clavicles, the first rib, and then all the soft tissue in the neck would give a lot of resistance. And so if you have an anterior lesion that appears to cross the clavicle, it's very likely to be coming from top down and not down up. So to put this in perspective, looking at this frontal chest radiograph, we see a mass in the superior mediastinum whose outline gets very hazy above the level of the clavicle and merges with the soft tissue of the neck. This suggests the lesion is coming from the neck and extends inferiorly down, likely an enlarged goiter, retrosternal goiter. In this case, we have this lesion that is seen very clearly outlined above the level of the clavicle, suggesting that it's posteriorly located, and it's because we have lung parenchyma on either side of it. That's why we have this very nice outline, as opposed to the soft tissues of the neck silhouetting this lesion here. So this is a negative cervicothoracic sign, and this is a positive cervicothoracic sign. I hope this has been helpful. The next thing we'll talk about would be prevascular compartment mediastinal masses. We'll give a number of differentials and how we'd identify them on imaging. Thank you very much for your attention. I hope this has been helpful. If you have seen value, give it a like, comment, ask any questions. I'll try to answer, and share with anyone you think might be interested in these sets of lectures. I'll see you in the next one.